Terrific. All right. Well, thanks for joining me tonight. I hope everybody's families are well, everybody's staying healthy and safe. This is a little unusual for me because I tend to be pretty interactive and use my hands a lot. So I'll try and stay as engaged as I can. Like I said, thanks for tuning in. This is a really, really fun subject for me. I like to say that I am this lecturer, and so for me, it's very fitting. As Sarah said, I am an orthopedic surgeon. I am sports medicine trained, but for those who know me or patients who maybe have seen me, they know I'm pretty engaged, both in the community and in my own health. And so I like to think about this talk in terms of not just treating people, but how I like to try and treat myself and what I need to do. So I like to say that I've been injured. I've been a patient, probably more times than I care to count. I've had surgery. I've recovered from surgery multiple times. And what I know about myself, and I think this is why I'm so passionate about the subject, is that I need a reason to train in order to train. I didn't grow up as the person who just loved going to the gym and working out on my own for the sheer passion of it. I needed a reason to do it. I needed the social aspect of exercise. And I think especially now, as many of us are feeling pretty isolated around our lives with the current situation, trying to find ways of getting outside, moving our bodies and exercising is even more important. So as we go through this, I think the topic is interesting because how we define a master's level athlete or a mature athlete is probably dictated by how we see ourselves and our communities and ourselves. So, you know, if you want to be specific about it, I think it would depend on the sport. So in some sports, it could be 40 and some it could be 50. For those who know me, I'm a triathlete. I've done Ironman a few times. And so those of us in the triathlon community, ironically look forward to aging up a little bit because every 4 to 5 years you go into the next age group category, and so it opens up some new possibilities for you to have success both with yourself and within your peer group. But when we talk about it, even though we're going to talk a little bit about exercise, I think it's pretty important to understand that no matter what you do, and I trust me, I know this, you cannot outrun, you cannot out-exercise, you cannot medicate yourself out of a bad diet. And so even though this is a very nice picture of me and now a very good friend of mine who is actually a patient of mine, who challenged me to do our first Ironman together, really the best thing that we can do is eat real food, eat clean, eat healthy, consume more fiber, and the less processed foods we're doing, probably the better we are. But that makes it hard because I know for somebody like me, I love food. I enjoy it. I enjoy the passion. I like cooking. And so for me, exercising is also a means by which I'm allowed to enjoy that food a little bit more. And so as we go through this and we talk about the different kind of things that we're going to do, I think it's also really important that we think about how that balances out against our life kind of in toto, and not just as we think about our shoulders. So as we age, there's a lot of things that are going to happen to our bodies, and some of the things we can maybe prevent and some of the things we can't prevent. But I think the big factors here is no matter what we do, to some degree, there is going to be a decrease in our lean muscle mass. And what that means is not just like our overall, like when we think about our body mass and our body mass index, there's lean body mass, there's normal body mass, but really what we're talking about is really muscle structure and muscle content when we talk about it that way. And so as we age, there's always a little bit of a decrease, and that starts generally around the time we're 30 actually, but really over 50, you start to lose a little bit more. Most of us are going to notice some of these other things in terms of, decreased ligament and tendon elasticity. And so ligaments connect bone to bone and tendons connect muscle to bone. And we notice that we have slower reaction times. Balance is an issue. It takes longer for us to warm up when we exercise. The decrease in cardiovascular health is an interesting one because that probably is one of the things that we can help and prevent. And the other big thing is osteoporosis. And it really doesn't matter if you're a man or a woman, and that doesn't mean that it's an automatic, but certainly osteoporosis is a World Health Organization diagnosis. But as a means of just losing general bone density, it's one of those things that's going to happen to all of us. And so when we talk tonight about some of the common things, especially around the shoulder, you know, the itises are always the big thing, which is the tendinitis, the biceps tendinitis and the rotator cuff, and to the distance runners and the weightlifters and maybe some of the more traditional endurance type athletes, we worry about stress fractures due to overuse in bone. And then the always pleasant back pain, which I thankfully am not going to get into because that could be a whole world of conversation on its own. But as we age, the things that we really need to be paying attention to are our balance, our strength, our tone, and our energy. So sarcopenia is really just a medical word for kind of age-related muscle mass. And so, like I said, that's one of those things that it's going to start in our 30s. But really, once we hit 50, like I said on this talk, we start losing about 1% of that muscle mass a year. So health body mass, or a healthy body mass, becomes a very important predictor when we look at public health aspects, or especially as we look at kind of general health, because it's a really good predictor of overall longevity and health spans. And so health span and lifespan are not the same thing. Health span is generally kind of a loose translation of how long we get to live disease-free. And disease-free can mean any number of things. That can mean anything from our heart-related issues. It can be kidney-related things. But generally what we're talking about is just that period where we've been able to maintain our muscle mass and stay, I don't want to say injury-free, but we've been able to stay pretty healthy as we move through. So when we talk about that volume loss, I think the thing that we're looking at is looking at these things in terms of the overall volume. And so, you know, if we think in terms of what we were when we were teenagers, and I don't entirely know who's on the call tonight, but I'm sure we can ask specific questions. You know, we talk about it in terms of these bigger areas, but when we look at, you know, our arms as we age, we still have strength, but we start to lose that mass, and that sense of kind of loss of mass, especially arms, is an easy one, because as we lift up our arms and we start to see, we all notice those changes in the mirror. So let's start out with just some basic exercise recommendations, and then let's kind of talk about the things that I think are important when we start thinking about an exercise program, because most of the people I know that I see, it's a pretty bimodal curve, and that just means instead of the bell-shaped curve, it means there's kind of two spikes in the curve, is a bimodal curve. Are the people who are already very active and very healthy and injured, and then there's the people who are wanting to be healthy, don't really know how to start, and they're trying to use either their family doctor, their sports doctors, their orthopedic surgeons, really try and help outline a plan. And that's really one of those things that's really terrific fun. So, you know, as a matter of just pre-participation screening, I think it's important that you start with a visit to your healthcare provider, physician, PA, whoever you trust, and they make sure that your heart and your lungs are really capable to do it. Because the last thing you want to do is start to jump into a health program where you have cardiac risk, and then you put yourself at higher risk, because we don't want the exercise treatment to be worse than the outcome of what we're trying to accomplish here. So it's a good idea to talk to your healthcare provider, let them go through those, and maybe go a little bit point by point so they can talk about what's the safest way to start. So I think there's some big factors here. So we'll go through each of them before we get into the fine points of the shoulder. But I think that the thing that we need to think about, and I'm going to use medical words, but I'll translate kind of back and forth. Resistance exercise, resistance training does not necessarily mean weightlifting in the traditional sense. So it just means that you're pushing some kind of mass, and that mass can be your body. But there are three elements to a healthy program as we move forward and as we age. One is going to be resistance. Two is going to be balance. And the third is going to be aerobic capacity. So if you're 45, and we joke at our sports meetings, if you think you're going to maintain your health by getting on, pick your machine of choice for 45 minutes a day, and that's going to prevent those long-term health risks? The answer is it's not. You really need all three. You need to work on balance, you need to work on strength, you need to work on the aerobic capacity. And so some of the things cannot entirely be reversed, but what we can do is try and work on slowing that progress and maintaining it. So when we talk about diet and we talk about protein is a big thing now, and it's always a big comment about trying in the kids to build body mass healthy, and in the adults trying to maintain their body mass. That's where we really kind of start talking about this 1.4 to 2 grams of protein per kilogram. With the one underlying exception is that if you have a medical condition, especially related to kidney disease, that does not apply. But generally, that's a good rule of thumb, is about 1.5 to 2 grams of protein per kilogram, and 2.2 pounds is 1 kilogram. So in the effort to try and maintain your muscle mass and maintain your strength, that's where you are. If you're trying to do less than that, or you're trying to lose weight, then we can kind of scale up or down based on that. For the people who are already very exercise focused, there's always a big fight about when do you take your protein? Do you do it while you're working out, right after you're working out? I think that's a little bit controversial. I think the more important part is trying to make sure clean, healthy protein, lean proteins, and really trying to maintain your exercise. You know, if we're going to just talk about the basic exercises, I think this is one of those things that most all of us can do, and we can get creative with this. So as far as I'm concerned, you know, really the big 5 here is a really effective way to try and work on all your exercises. So calf raises as a matter of exercise, trying to work both on your foot and your lower knee exercises are safe. With or without weights is fine. Using a stair or a step up is acceptable. Squats is one of those things that we always get challenged on when I start talking about people, talking to people about their exercise programs with squats. Lunges, step back lunges is always a biggie. It seems a little counterintuitive that that would be one of the exercises that we want to use. But the reality is that when we're doing those things, really what we're trying to do in many of these exercises, especially lower body exercises, are something called a closed kinetic chain exercise. And what that means is focus on exercises that work multiple muscle groups at once. And so with the exception of, say, a biceps curl here, each one of those things that I'm pointing out is really focused on multiple areas of the body. And so the bridge exercises, which you can see in the upper left, up in here, is really going to be focusing on the core. If you don't have great power, you can use a block. There's all kinds of ways to do it. I think if you go to the right and we think about the squatting exercises, I always like to teach my folks, especially the athletes who are coming back from exercise, or back from injury or back from surgery, is that I want you to think about doing a squat to a chair, and that could be a high chair, it could be a lower chair. But the idea is that as you work from the negative back into the positive part of the exercise, that you have something to sit down to, take the pressure off, and then roll back up and press up through your heels as you do that. Shoulder exercises, I think, especially as it pertains to our discussions today, are going to be very important. So things where you're elevating your arm out to the side, or for either a forward raise or out to the side, those are the things that are going to be much safer. The things that I don't want my folks doing, especially in people who have predisposed conditions around the shoulder and the rotator cuff, are the things I don't necessarily want them doing are the overhead pressing exercises, because those are the kinds of things that really put a lot of pressure on the rotator cuff itself, which we'll talk about as we get into this a little bit further. Balance is the second component. Balance diminishes with time. And it's also one of those things that we can really, really help ourselves with simple things. We don't need to be doing long, dedicated exercise programs to work on balance. But as we age and we lose some of our balance, that's really where we start to get into these fall risk problems. And I think that's one of those major factors that everybody needs to consider. So when people ask me, well, how can I do that? It doesn't necessarily mean that you need to be at the gym, lifting weights, standing on a BOSU ball, trying to do these major balance exercises. The idea is that you're trying to do single leg stance as a simple way to start, ideally 30 seconds at a time, and you switch. When I do it for myself and for my own health and my wife, we're really talking about doing things where I'm standing on one leg when I'm brushing my teeth. If I'm standing at the kitchen sink and I'm trying to do some basic things, If I'm lifting warm up or I'm doing light weights when I'm starting a warm up exercise, I'll try to do it either on a foam. I'll try and do it single leg sets, things which will then are forcing me to engage my core middle section so that I can really be working on my balance. And I will say that my balance is horrible, so I know that this is one of the critical pieces for me in my own life, trying to get myself and maintain my health. But when we talk about treatment and treatment of injury, this is where it gets a little bit interesting, because we say we don't want the treatment risk to be worse than the injury risk. So when you're thinking about recovering from either injury or when you're trying to get back to a program that maybe you haven't done in quite a long time, you'll notice that you get, we call it DOMS, or delayed onset muscle soreness, after you've been back in your program. And that's because you're starting to use the muscles in a different way. You're starting to really kind of reactivate the neuromuscular fibers in a way that they haven't really been worked. And so rehab and analgesia, or pain management, are just components of those things as we try and get back into our usual exercise programs. Either, like I said, you haven't been at it for a while, or you're trying to come back from injury. But when we talk about these things, many of these recommendations about ice, heat, red light therapy, laser therapy, dry needling, there's lots and lots of evidence that goes both ways. And so there's always a little bit of conflict within the medical community as to, which is really the best thing that's going to be for you. So, I think using things which are safe, things which have really good scientific data is the way to go. So, for anybody who's used a foam roller, I tell my folks, if you're going to use a foam roller, of which I am a fan, expect that you're going to want to cry. It hurts. And so that comes back to the treatment risk, injury risk thing. You're not going to be injured necessarily using a foam roller to try and help with some myofascial release exercises, but know that it's likely going to be quite uncomfortable as you start that program. So rest is an interesting thing. Rest after injury, rest is relative. And so what I have a long family history of obesity. And so even though my family is not generally obese anymore, it's, I think, our fear of that drives a lot of us. But my dad was a very, very good competitive master's level runner for years in the marathoner. And the guy was a machine. How he ran the distances he did is beyond me. I never had the passion like he did. But what I learned from my dad and all of his injuries, especially going into sports medicine, is that you never tell a runner not to run. So what I learned from that is, when I say that, I say it a little bit dismissively, because I used to watch my dad go from doctor to doctor to doctor until they told him what he wanted to hear. The idea is that rest with injury is relative. So absolute rest, meaning total shutdown, for the vast majority of us is a non-starter. It is never, never okay to do absolutely nothing. So I don't care if you had your ACL fixed or if you had your rotator cuff fixed, total and complete rest is never acceptable. There has to be another way to exercise. The cardiovascular elements are too important, and you will lose your base so quickly that we have to always start that when recovering from injury or starting a program. To me, rest is a non-starter. So that usually leads to, well, doctor, when is it okay to exercise with pain? So I think this is an interesting one, because as most of us get over 40, and certainly as we get into our 60s, we all get a little bit of what's called tendinopathy. And so tendinopathy is really just normal aging that you'll see in most all tendon tissues. So again, if tendon connects muscle to bone, usually there is some degree of degeneration that's going to happen in those middle layers. And so if we have like multiple layers in a tendon, usually those middle layers there will start to degenerate a little bit, especially as they lose some of their elasticity. So if most of the tissue should feel like, oh, I don't know, it's maybe like a nice rubber band or thick rubber band, what you start to see, just like in an older rubber band, is that you'll start to see those little cracks in it, and it starts to fray a little bit. And so the same concept holds, that as we age, it still has the elasticity, but it comes just a little bit more brittle, and it's a little bit easier to injure. So we have to be careful as we do the exercises that we avoid the things that are putting high stress on those areas. But again, please do not stop exercising. There is never an excuse for complete rest. It's too important for us to maintain our cardiovascular health, our muscle mass. My rule, and that's kind of not hard and fast, but just general rule, is that if your pain is about a 4, you're probably okay to keep exercising. And a 4 to me may not be a 4 to you. And so it's why it's very self-perceived. And that's okay. But if you feel like a 4 to you seems wrong, then that's when you go and talk to your healthcare provider and let us really try and walk you through those things. The next thing that usually leads to after the injury and when I have pain is that I want an MRI. Or even better is the people who get to come into our office who already have the MRI. So I say this all the time to people, and patients who may be on the call tonight, you've heard me say it, I'm sure, is I treat patients, I don't treat tests. And so I think it's really, really important that you interpret the results of these, especially for those of us over 45, and definitely for those around the shoulder over 60, that you interpret the results with a little bit of a grain of salt, especially when you start talking about the shoulder, the knee, and the back. What I mean by that is it's gonna show something. Like, you can't age and continue to have a normal scan. It just isn't gonna happen. The question becomes not what's the finding of the MRI, but is the finding of the MRI consistent with the problem you have? And then is it bad enough that you feel like you need an operation? And that's how I approach the results with the MRI. So again, as we age, we all have some things on our MRIs. So don't get too hung up on partial tears of this, or degenerative signals in that, or my knee meniscus is this, or I have a partial tear on the rotator cuff, or I have tendinopathy of the long head of the biceps, and we'll talk about those things too. Again, we're all going to have a little bit. It's do the tests, match the findings, and have you tried the conservative things before we go rushing to operate. So which exercise is best? And I think the answer to that is really pretty easy. And the answer is the one that you enjoy and the one that you'll keep doing. For me, like I said, exercise needs to be social. You know, with my life and my lifestyle, I'm at the office, I'm in the operating room. My opportunity to see my friends is when I get to exercise, whether it's a group fitness class, which is clearly a problem right now, or outside running or biking. But I think that those are the things where you need to find the community that you like to surround yourself with, that you can commit to seeing and being, to do healthy things, which are going to encourage you to be better and be healthier and better with yourself. So whatever that looks like is less important than just finding the community and finding something that you'll enjoy and that you're going to commit to. So what's the recommendation then around that? So there are, I think, are a number of things that we can talk about when we talk about exercise recommendations. One is the American Heart Association's recommendations versus an orthopedic surgeon's recommendations or a sports medicine provider. What the American Heart would say is they ideally would like 20 to 30 minutes of moderate to vigorous exercise 3 to 5 days a week. For many people, that's going to be unreasonable. And especially if you really haven't done anything for a while, I think that's probably really a setup for failure. But I think it's something that you can do, and it doesn't have to be 15 minutes straight, whether you're going out for a walk, a bike, God love you if you like getting in a pool, a lake, whatever it is. I think that you should be finding something that you can do with some degree of relativity for about 15 to 20 minutes per day, average over a 7-day week. And you're allowed to take a day off, but you really should be shooting for a good 5 days a week where you're hitting those numbers. And so the old 10,000 steps that we all get on our nice watches now is really not based necessarily on an absolute number of that. Criteria is set for matching to the American Heart. It's just a generality of, if we get 10,000 steps, that generally takes us into that 20 to 30 minute range, which is why we feel pretty safe using that as a starting point. The other thing that we'll sometimes see after joint replacement, can you exercise, can you run? I think the decision about running after hip and knee replacement is up to your surgeon. Probably avoiding the high impact sports is a pretty safe thing. But whether you're doing that after shoulder replacement would say the same thing, is we don't necessarily want to tax it with high load, but it was designed to use the chances of you wearing out a joint replacement are exceedingly small with today's technology. It's more about trying to maintain the muscle and the muscle mass in a safe and effective way. I think we've talked a little bit about rest. We've talked a little about recovery, so let's kind of keep moving on. All right, so let's kind of get into the meat of the shoulder now. And so I broke this down really into 5 categories. And I think these are the big 5 that most people will see when they're coming to talk to us. So arthritis, and arthritis can mean a number of things. So I'm going to generally talk about arthritis in the course of what we call osteoarthritis. And by osteoarthritis, we're talking about just normal wear and tear. The joint surface starts to wear out. I often use the analogy of, looking at the white shiny surface on the end of the chicken bone. I'm sorry if I offend any of our vegans, but the concept is that you're looking for like a nice white shiny surface. When that starts to break down, those are the things that we start to see when we get arthritis. The labrum, which often is one of those things, especially when people are coming in, and the people who have had MRIs, the labrum is really just the cartilage ring. When we think about the shoulder, I describe it in a number of ways. And we'll talk about a little anatomy in a second. But I talk about it as either a golf ball resting on a tee, where the ball is larger than the cup itself. And the labrum is just the ring of cartilage that goes around the cup to deepen the socket so that the ball doesn't fall off. Then there's the rotator cuff, and the rotator cuff is really made up of 4 muscles that then merge together and kind of attach onto the arm bone so that your arm can move around. And so I start to use these words: the supraspinatus, the infraspinatus, the subscapularis, the teres minor. I promise there's no test, but really the biggie is the supraspinatus, which is the top part, which is attaching right on top of the arm bone. Rotator cuffs can have full thickness tears, they can have partial tears. We'll talk about that. Biceps tendon, which generally to us means the long head of the biceps. So the front of your arm has 2 bundles. One comes up the front of the shoulder and one comes over towards the inside. One's called the short head, one's called the long head. And then joint stiffness, I'm using loosely. People will often talk about frozen shoulder, but let's just kind of use this as a grouping of something more for joint stiffness. Now, when we talk about osteoarthritis, exercise by itself does not cause osteoarthritis. What we do, however, see, and I'm not expecting anybody to be throwing a 90-mile-an-hour fastball here, especially with that kind of load and torque on the arm. But what we generally have accepted is that people with arthritis have lower pain scores than people who do not exercise with arthritis. So it often seems a little counterintuitive, but using the joint, keeping the mobility, keeping the planes moving, reduces the inflammation in the joint. So even though you may have a little bit more pain while you're exercising because of the arthritis and it's not perfectly smooth anymore, what we do see is that over the course of a 24-hour period, people who have consistently exercised have lower pain scores. And I think that's a really important thing, because it comes back to can I exercise if it hurts? And the answer is yes. It's the degree and the intensity that you're working out that really is going to drive some of these decisions about how hard and the type of exercise we do. But again, the last thing is bad sounds don't always mean bad things. And so, you may have a little bit of that Rice Krispies sound, and I know I date myself just by saying Rice Krispies because a younger generation doesn't even know the smack, crackle, pop concept. But the idea that you're making some sounds doesn't mean anything bad. It's, do you associate the pain with the sound? If you have those 2 things together, we probably should talk. But generally speaking, you don't need to rush to the orthopedic doctor or your sports medicine doctor because you're making some sounds in your knee or your shoulder. So let's talk about the basic treatment options here. So mobility is always number 1. You don't need me for that. You don't need a surgeon to help with that necessarily. You may need a stretching program. You may need some help with a trainer. You may need a brother, sister, exercise group to do group classes. You may need a physical therapist. All of those things are certainly acceptable. because you're trying to maintain the range of motion as best you can, because that's the thing that prevents further collapse in the joint. We generally talk about using higher repetition, lower resistance. Well, what does that mean? What that means is that when we're talking about these exercise programs, I'd rather you were doing 15 to 20 reps per set, using no weight or light weight, and really focusing on form. That to me is the critical piece to try and maintain the mobility of the joint and the muscle mass around it. When we start talking about non-traditional therapies, I think that really becomes a relative thing. So whether we talk about stem cell treatments, and we can talk about that tonight afterwards, whether we talk about, like I said, laser therapy, red light, LED, near infrared, dry needling therapies. I think those are the things which have a lot of interesting possibilities, maybe as an addendum to a program, but as a treatment by itself, I'm not sure that that's really necessarily the best. Biologics, I use this word as kind of a grouping, and I think biologics can mean something called PRP. It can mean, I would use the word stem cell a little loosely, because that's really not the word we're supposed to be using anymore. We're really supposed to be talking about, sometimes we call them medicinal cell therapies, or mesenchymal cells, but signaling cells, the cells which are then triggering the body to try and heal itself. Arthroscopy as a form of treatment for surgery, which is kind of the cleanup, has very narrow indications, but it is under the right circumstances an indication. And then arthroplasty, which is what we call a joint replacement. So I thought it'd be fun to just look quickly when we talk about arthritis to kind of talk about these things so people have a sense of what it is. So if we go from the left to the right on the screen, these are the first two are the x-rays. So if you look at that first x-ray, you see the spacing here, and I hope my arrow's showing up. You see that there's nice round surface on the ball. You see the cup. If you turn this 90 degrees on its side, you could start to understand the concept of, the golf ball resting on the tee. But as the ball starts to wear out, as this becomes less round and becomes flattened, we start to see in the second picture where it's not perfectly round anymore. It's a little whiter in the middle. You see these bumps starting to form on the bottom of the bone and on the top. In medical speak, that's called an osteophyte. Sometimes people talk about bone spurs. Generally, when we talk about a bone spur in the shoulder, though, we're talking about a bone spur that comes off the roof of the shoulder blade called the acromion. But when we open up the joint, what we start to see is this. And this starts to look almost like polished rock. You're not really seeing any healthy cartilage on this anymore. There's no white, bright, shiny surface. This is all exposed bone that's been rubbed and rubbed and rubbed. And that's what happens as the cartilage wears down. So those are the people that we start talking about the replacements. And a replacement is when you then remove that part of the bone there, you then machine the inside of the bone to accommodate a stem. And the newer replacements don't necessarily use, this is an older film, don't necessarily use these longer stems anymore. They're now using much shorter stems and much smaller posts in here, especially on a younger population, because we're trying to be more bone sparing. Okay, so let's move on to, because I think this is a good natural segue, as we go from osteoarthritis to adhesive capsulitis. So adhesive capsulitis is a fancy way of saying frozen shoulder. It's very common that we will see people in the office coming in and they were told they have a frozen shoulder. And yet nobody's taken an x-ray. And when you look at their x-ray, they really have that. It's very unusual to see someone who has a frozen shoulder also having osteoarthritis. If the joint is arthritic and the capsule that surrounds it starts to get tight, that's a function of that not smooth issue. A frozen shoulder is when the capsule that surrounds the joint gets tight, but the surfaces that are rubbing are really still very, very smooth, and there's nothing wrong with those surfaces. Now, a frozen shoulder can come up for many reasons. It can be what we call idiopathic, which is just we don't know why you got it, which is the most common. And then there's the secondary forms, and that can be post-traumatic. It can be people who have endocrine disorders. Unfortunately, there is a group that tends to be women in their 40s, often people who have a history of diabetes or thyroid problems, that and over 40. Those four, that is a little bit of a higher propensity in that population to get it. But the medical word for this now, and this is where the things start to blur a little bit between frozen shoulder, arthritis, and just stiffness, is when we start talking about these things called synovial hyperplasia and capsular fibrosis. So it makes me sound smart when I put it down, but all that means is fibrosis is scar, capsule is just the saran wrap that surrounds the joint, and the synovium is just the joint lining that lines every single joint in the body. It makes the joint fluid, but when it gets thickened, that's called synovial hyperplasia. So you get a thick joint lining with a thick capsule, and those are the things that go along with the traditional frozen shoulder. But when we talk about frozen shoulder and treatment, really we can break it down into a number of things. And I think it's important to know when you talk about frozen shoulders is you have to know the natural history of every one of the things we're talking about tonight. So like an osteoarthritis, arthritis is, at this point, it's irreversible. Whether you choose to do this with, treat it with a stem cell conversation or not, the concept that, you know, if you're going to talk about stem cell or ozone or any of these things, that you're going to inject something into your joint, that it's going to magically turn into a new joint, that is not what this stuff does. Those types of injections are to stimulate a healing response. Those injections are used to try and get your body to try and heal and try and stimulate that healing response, because it is not, there's no way you can inject at this point in time anything into a joint and regrow cartilage. It's just not there. The reason I say you have to know natural history is when we look at a frozen shoulder, if you do nothing for a frozen shoulder, they get better over time. Everything that we do in medicine to try and speed up the treatment of a frozen shoulder is just that. We're speeding up time, we're speeding up the natural history. We are not changing it. So if you do nothing for a frozen shoulder, it will likely get better. You will likely lose a little bit of your internal rotation, but it's just going to take about 18 to 24 months to get better. Most people aren't willing to accept that, which is why we initiate treatment. So physical therapy is generally where we start. I think therapy plays the most critical role in the treatment of a frozen shoulder. But here's the problem. When you start treatment for a frozen shoulder, there's 3 phases to a frozen shoulder. So there's a freezing phase, there's a plateau, and a thaw. And so why that's important is that if you initiate treatment, and by initiate, I say start physical therapy per se, during that freezing phase, guess what? You're gonna get worse. And so that is a very common scenario where you come into your provider and you say, I've already done therapy, I'm worse, I'm not going to therapy again. That's where you really need to understand the natural history, because if you initiate while you're still freezing, it's not going to get better right away. You need to hit the plateau before you start the treatment. So that's where we start to move into manipulations and injections. And I left injection off kind of purposefully because those are the things that we're trying to do. An injection is going to help distend the joint and open up the space. Manipulation is when we do what's called manipulation under anesthesia, which is where you give people sedation and then you move it. But whether I manipulate it or I do a capsule release, which is an operation, I'm still back to the therapist to try and maintain and gain the motion that I just got. These last 2 options are things that I'm doing surgically to try and speed along the natural process so that I can get you back to the therapist so we can try and move those things along. So let's just talk quickly about rotator cuff anatomy. So like I said, there's 4 muscles of the rotator cuff. The top one is the supraspinatus here. It comes across underneath the collarbone and attaches on the top of the arm bone. From the front view, we have the subscapularis. We have the subscapularis, which is this big group of front muscle which attaches to the front. On our back view, we have what's called the infraspinatus, which is coming below this spine here. We call that the spine of the scapula. And then the very, very bottom one is the teres minor. So the infraspinatus and the teres minor are externally rotating your arm. The supraspinatus is going to elevate you out to the side, but at rest, the supraspinatus holds the ball in place. So when we're exercising, it's an elevator, but when we're at rest, the supraspinatus is holding things in place. So what's this? This is people coming all the time. They ask about impingement or external impingement or bursitis or subacromial bursitis, and that's the SA is subacromial. And then the other is what's this bone spur thing? And so when we look at the shoulder, when we look at the roof here, this is the acromion part of the bone. As you build up extra bone on the outer edge, it starts to create an arch where it starts to rub on the rotator cuff below. And so what we call external impingement, or the classic bursitis problem, is when you start to see that space then starts to narrow and the rotator cuff can't glide so smoothly underneath the bone and it starts to rub. And so in the most basic form, in people who have really large spurs, it's kind of like your sock rubbing against the back of your shoe, where you start to see it just slowly starting to wear a hole. And like I like to tell people all the time, is like when I'm fixing a rotator cuff, I'm just darning the sock at that point. I'm just sewing that back onto the bone. It can be a problem with repetitive load. It's why we talk about trying to avoid overhead pressing repeatedly, because you're driving that rotator cuff into the roof as you're doing those things, which then lead to further inflammation, more swelling in that fixed tight space. And in someone who already has that tendinopathy, which we talked about as just that normal degeneration, as that starts to happen, it makes it easier for those delaminations to occur in the layers. So as a generality, there are multiple parts of a rotator cuff issue. There's the mechanical part, which is just the rubbing. There's those micro tears or partial tears in those deep middle layers. And then the last is what's called hypovascularity, which is the blood supply to the rotator cuff comes from the top down. And so if you're already pinching from the top, as the blood vessels are trying to penetrate in, those deeper layers never get the blood supply and they start to thin from the deep layer down. The bursa then becomes this space, which is between the rotator cuff here, which is the white, and the roof of the shoulder blade, which is the acromion. And the bursa then is to help things glide. It's just a little potential sac. And so when we look at those things under arthroscopy, this is the kind of thing now that we're looking at. So this is an actual picture of a patient of ours where the rotator cuff here is the tendon, which should attach down on the bone, which is yellow. But before this became a full thickness tear, it starts to delaminate. And that's why I like this picture is you start to see that little delamination or that thinning on that back corner before it finally goes. And so what here is, this is the biceps tendon. So when we're doing surgery to repair these, we're trying to get rid of this bad, unhealthy, yellowy tissue, put stitches into the healthy so that we can then sew that back down onto the bone. And that's really what a rotator cuff tear is. But can a partial tear lead to a full thickness tear? The answer is yes. But it takes quite a bit of time. It's not going to happen in months. It's going to generally happen over years. And so when we see people who have had shoulder problems who already have partial thickness tears, I like to say, I don't want you to disappear on me. So it doesn't mean that I'm automatically going to re-ultrasound it. I'm not necessarily going to re-scan it, but I do want to keep an eye on you to make sure that if you're in that pool where you're getting a 50 or 80% loss of volume in the rotator cuff, I want to make sure that I can follow this, that the partial tear doesn't necessarily go on to the complete tear, which then maybe would need surgical intervention. So 80% of the partial thickness tears will go on to become full thickness tears over the course of 2 years. But it's A, not an absolute, and B, it depends how big that partial tear is going to dictate whether or not we're going to have to go and do something, because only about 8% of those partial thickness tears will increase over those 20 months. So it seems, how is this possible? But the data is very conflicting here, because we know that the natural process is that the cuff will continue to thin, but once we identify them, it may or may not be symptomatic. And so it's why the data gets so conflicting is if we're taking large populations of people and scanning everybody, some of the people are going to be symptomatic and some of the people aren't going to be symptomatic. And so that's where we really need to use our clinical judgment in trying to decide which is the best way to go. So let's talk about a rotator cuff program and let's talk about the basics. So I think the 7 that I like to talk about here are the things that you can do at home, which don't really require tons of equipment, if any. So when we talk about the arm reach exercises, we're starting to talk about the things that are going to be out to the side, the things that are going to be forward up. And again, I don't care if you're using weight or not. You can use body weight for all I'm concerned, for all I care. I just want you to be doing it in the plane, trying to do 15 or 20 at a time, trying to do 3 sets when you do it, shooting for 2 or 3 times a week. That should adequately address it. The side lying external rotation things, that's if you're lying on your side and then you're trying to use your arm to rotate out. Again, if you have an arthritic joint, your range of motion is not going to be the same as someone who's a professional baseball player, but that's okay. If you're keeping your elbow in tight when you're doing your rotation exercises, or you're keeping it in what we call pure plane forward or out to the side, those things are going to be pretty safe. Pendulum exercises, which are the things that we just do standing up and letting dangle. Cross arm stretches where we're using our body across. Door exercises where you're kind of holding to pull yourself back, trying to stretch that front part of your shoulder in there. Those are the things you don't need equipment for. A lawnmower can just be a rowing exercise where you're pulling back from a bent over position. If your back doesn't accommodate it, it's fine. Then do an upright rowing or do it backwards where we can tie something to the door handle. We can be pulling down. The idea is that we're trying to maintain both the front and back of the shoulder at the same time so that we can maintain our strength. Now, as we move on to the biceps, I think this is the next thing that we talk about, which is biceps problems go along with rotator cuff issues. So when you look at a picture like this, and this is an arthroscopy picture, what I'm looking is this is that white shiny surface that we'd like to see of healthy cartilage. The front part here, and so we're looking from the back into the front. This is what's called the subscapularis, that's the front rotator cuff. And then the top part up in here where it's listed as rotator interval is the area that covers over the top of the biceps. That's the classic part of the rotator cuff that we talk about, which holds that biceps down in place. And so when you think and see this picture, you can see where the tendon attaching across the bone is going to hold the biceps in place. But just like the rotator cuff can get that tendinopathy, so can the biceps. And so you do start to see a little yellow discoloration as you get that normal aging process. How we address it surgically or non-surgically is largely based on the stability and whether or not the biceps is torn. Almost always the therapy for the biceps is the critical and most important part. So I want you to see the reason, and I think that's what's good about this picture here, is the biceps has 2 muscle groups. One is the straightforward shot that goes to the front part here called the coracoid. And then the long head, which is the part that comes up, hangs this left turn and attaches deep in the shoulder. So the longer the tendon is, the more it can have problems. Same reason the Achilles does, the long head of the biceps do. Things where the tendon is longer and under more tension, and especially in the case of the shoulder where it's going to hang a left turn going into there, that's where it starts to get inflamed. So the rotator cuff, which is removed from the picture, would then normally overlie and attach on the bone here, but its job is to keep the biceps in place. So if the rotator cuff is lifting up, the biceps is allowed to toggle back and forth, you start to see this inflammation starting to form. So the exercises that we do for a biceps problem, modalities in our speak can be hot pack, cold pack. In therapy speak, it can be ultrasound. Those are the components that we're talking about. But those exercises that we really want to see people doing are the things that are going to work on both the strength of the biceps, really from a seated position. We kind of talk about doing it just forward and back. I don't necessarily need people swinging their whole body in space, throwing their arm around. That's not what we're looking for. We're trying to maintain, we say, pure plane exercise, focusing on the front, either a hammer curl, which is a neutral, or a supinated arm, kind of bringing it up. Those are the things that we're talking about. Sleeper stretches, sorry about that. Sleeper stretches, which we'll talk about in a second, are the things that we're going to really be doing to try and maintain mobility and strengthening. So when we talk about that vast options, traditional treatment would be, ice versus heat. Those are the things that we talk about, the relative rests, meaning don't aggravates the tendon and strengthen around the tendon. That's the problem, not the tendon itself. Non-steroidals, steroids, whether it be an injection or a pill. Injections can mean a number of things. Injections can be anything from cortisone. It can be a sugar solution, it could be a dry needling, or it can be these growth factors. And then surgery really is the last treatment option, which I don't really want to go into today because biceps problems by themselves as a surgical intervention actually isn't terribly common. But those biceps exercises are often similar to the rotator cuff, which makes sense, right? Because the same reason the rotator cuff keeps things in place is the same way the biceps keeps located in its groove. And so those are the things that we want to do. So these bicep stretches where we're bringing our arm out to the side, those things where we're really doing those active curling exercises. Trying not to rotate the forearm through as we do those exercises is an important part because it puts more force on the front part of the shoulder. So we really want you doing it either straight, reverse, or forward, but that what we used to call the concentration curl of that full curve, I don't really want you doing that if you're trying to recover or rehabilitate an already injured. The sleeper stretch is this thing where we're doing that where we're laying on our side, really trying to bring the arm into internal rotation to stretch out the back part of the shoulder because notoriously in our lives, we will focus on being out, but we don't necessarily focus a whole lot with being all the way back in. And so I think focusing on exercises that work that back part of the shoulder, especially as part of a stretching program, is really a critical part to trying to maintain your shoulder and your joint health. So that basic sleeper stretch is what we're talking about, where you're laying on your side. Sometimes you'll put a towel underneath the elbow, and you're just trying to work back into that internal rotation. The side stretch or a bicep stretch where you're pushing your arm against that area, against the wall, trying to rotate the arm to try to get that stretched out, are the things that we're trying to work to stretch the whole front part of the shoulder here and out into the arm. I think that's a pretty vast review. I think a quick summary is probably in order, and then I'm sure people will have some questions. So, you know, I think the most important part, and I spent quite a bit of time on it, the critical part of that is exercise is critical to achieving and maintaining our best health. I think that balance and strength training are one of those things that are often overlooked, but are critical to maintaining our lean body mass and our healthy body mass. Please speak to your, I don't care if it's your doctor, your PA, your nurse practitioner before you start a program, because those are the people who can really kind of check your cardiovascular risk before you start doing those things. Don't jump to an MRI so quickly if you don't already have one, because again, the MRI cannot be unseen. Rest is relative. I'm never going to tell you it's okay to do nothing. Respecting your body as part of the recovery is what we talk about with trying to maintain exercise in other ways to avoid re-injury so that the treatment doesn't become worse than the injury risk itself. And always, 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 the best exercise for you is the one that you will do religiously. So with that, I'm going to say thanks, and I'm happy to open it up to any questions. Okay, so the big question is stem cell for the rotator cuff. I think this is really, really fun and exciting stuff to talk about right now. There's a couple of things that we need to talk about, and I think it's good that we do that when we think about it relative to our conversation about partial tears and full thickness tears, because once the tendon has really been pulled all the way off the bone, there's nothing I can inject into there which is going to mechanically put it back on there. I think where most of us are using, we'll call those biologics, and we'll kind of break it down a little bit, but most of us who are using biologics, we're trying to use it in the people who have partial tears primarily. I think that's the most important one. Or the people who have those tendinopathic or those deep layer tendons where it's not actually torn yet, but it's starting to delaminate from the inside first, because the mechanical component of the tendon attaching on the bone, it can't be injected back. It has to be reattached if that's the issue. But when we talk about the different biologics, I think people use stem cells as really large grouping of category. And when I think about stem cell, to me, I'm really thinking about cells that, mesenchymal cells that can become anything. And there's really only two good sources for those. One is from yourself, the other is from someone else. But the ones from yourself are either coming from your bone marrow or they're coming from your fat, because that's where those cells are most densely populated. The thing that most people are doing, though, for these partial tears, and sometimes they're calling it stem cell, but it's really more of a growth factor injection, is when you're doing something called PRP. And the PRP is platelet-rich plasminogen. And there's multiple companies that have the kits, and each of them have their own little idiosyncrasies on why we like them, Buffy codes, white cell counts, things like that. But the idea is that when you're doing PRP, you're drawing blood from usually the arm. You're spinning it, you're separating the plasma and the serum, you're taking the platelets out, you're breaking the platelets, and then you're getting the growth factors out of the platelets to then inject that back in. So I think in the face of a biologic injection, I think partial tears, absolutely. I think there's really, really good compelling data on that. But once the tendon is fully torn as a treatment by itself, and not just as an augmentation to a repair, I don't think it's going to work. My personal take is that I think there's lots of compelling evidence with regards to acupuncture as a means of pain and chronic pain. I think there's really good and increasingly compelling data on light and light therapy, specifically red and near infrared lights. I'm not as well versed on necessarily the ozone as a treatment in terms of an injection. I personally am a fan of the acupuncture as a means of managing pain. I really don't have any experience to comment on. It's a matter of the shoulder and the rotator cuff. Okay, so the question is around, I'm going to talk about this in two ways. So one is the person who's already had surgery, and then let's talk about the person who has these near complete tears of the rotator cuff, but they weren't fully torn off of the bone that are repaired. And sometimes those are called in situ repairs, where you leave the deep layer attached and then you sew the top down, or vice versa, whether you keep the top layer and you sew the bottom layer. I don't generally have a problem with certain kinds of overhead pressing, but the concept that in your case, if you're a post-surgical patient where you're already repairing not the healthiest tissue back onto the bone, there are very high re-tear rates in those over 10 to 15 years. And so the exercise program that I like to see is a mixture of front and back stretching, forward raises, side raises, really not, sorry, my suit's kind of uneven, but not past parallel to the ground. Yeah, that looks better. Whether you're coming forward, oops, sorry, I don't want to hurt you, Sarah, or to the side, I think those are great. I really encourage my folks to stay away from flat bars, especially people who have had prior shoulder surgery. Olympic lifting worries me, especially big throws. And the heavier overhead presses I don't love, because you tend already to fall to your weak side. And so if you have a fixed weight overhead, you're going to fall to that weak side, and I prefer you do it. So if you really love a military press and it's an important part of your program, then you need to be doing that with dumbbells. And I even encourage them to take it a step further. If you're going to be doing some of those programs for your shoulder as your maintenance program, I would either be doing it on a large fit ball, so it's an uneven surface. And the reason I like that is it then forces you to drop your weight. And so you can then engage your core at the same time that you're doing your shoulder workouts, so that you can try and drop your weight, keep it in that, at that point, if you're recovering in 10 to 15 rep sets. And I think that's just a safer way to go about it. Okay, so the question is around the biceps tendon. Let's make sure we're talking about the top. We're going to talk shoulder, and we talked about the two branches. There's the short head and the long head. A short head tear virtually doesn't occur. So let's just assume for a minute when we talk about biceps problems, we're talking about that long head, that long tendon that's hanging the left turn there. If you tear the rotator cuff, there's a very good chance that you're going to get a biceps tear, or at least biceps instability. If you tear the biceps and you don't have a rotator cuff tear, then it is not a foregone conclusion, nor should you expect that you're going to go on to have a rotator cuff tear if your biceps is torn. Treatment of long head biceps tear complete is a different conversation, surgical versus non-surgical, but no, the short answer is no, you shouldn't really be worried that you're going to get a rotator cuff problem because your biceps tore. Oh, supplements that's an interesting one. So, if we try and look critically at the data on supplements on this, let's start with the basics. So, if we think about glucosamine and chondroitin, glucosamine and chondroitin are really two structural proteins that live inside our cartilage, and you can use those. And this is where I think people get a little bit of nomenclature kind of mismatch. So. Glucosamine and chondroitin have excellent data for help and treatment of arthritis as a means of a nutritional supplement. Often, if you're at some of the bulk food stores, they'll also package it with MSM. MSM, the data is good. It's just not as good as glucosamine. So glucosamine is best, chondroitin is second, MSM third. The next is that we talk about hyaluronic acid, which we do as an injection in the knees commonly. Hyaluronic acid you can see as a supplement. You can take that. You can take the collagen all you want. It's denatured in the stomach. It does not really get absorbed. The data is just not nearly as compelling as that as a supplement to maintain your strength and your health. You're better off if you're trying to do that, eating clean, lean proteins as a means of trying to maintain your mass, especially around your joints. Okay, so let's talk about the AC joint. I didn't really go over that tonight because it's one of those things that we see a little less commonly in the more mature athletes. The AC joint is where the collarbone meets the shoulder blade there. And so if you think about how the shoulder is structured for a second, the collarbone kind of adjusts from the chest here, comes out to the side and attaches out of the shoulder blade, and it meets the roof of the shoulder blade. But really the only point where the shoulder is fixed to what we call the appendicular skeleton to the axial skeleton. So our arms meet our spine, or in this case, the chest bone, is through the collarbone. And so when you separate your shoulder, it tends to be either a fall. Mountain bikers get them all, bikers get them, collision athletes get them all the time, where you fall either onto an outstretched arm or you strike the top of your arm and it pops up. People's collarbone is popping up. It's actually not that the collarbone popped up, it's that the shoulder dropped. But there are multiple ligaments that hold the shoulder blade and the collarbone together. And so we as providers usually think about the AC joint in terms of 6 types of injuries. The most rudimentary thing is that if you have a 1, 2, or a 3, don't operate. If you have a 4, 5, or a 6, you may need surgery. But the treatment is generally, if the collarbone hasn't popped up too much, is you use a sling for rest to manage the pain. You initiate passive range of motion as soon as you feel comfortable doing it. And then as soon as you're able to, you can start reintroducing a strengthening program, especially even chest exercises, pressing exercises at your pain tolerance.